Hello, everyone. Happy Monday. Also, happy Endometriosis Awareness Month. This is a month to celebrate, raise awareness, and just spread the word about endometriosis. So, today I have a treat for you guys. We are going to be talking to an endometriosis specific dietitian to talk about what endometriosis is, how you diagnose it, what the treatment options are, what the diet recommendations look like. So we are going to talk about that, and we're also going to tie it into interstitial cystitis and how the two conditions essentially can be connected. So let me get her on here. I think I just did that wrong, Steph. Bear with me. Steph, can you request to be? Oh, yay!
Ooh.
Hallelujah! Every time
The camera always does that.
I put
Why?
it up, I don't even know. Oh my goodness.
How are you?
I'm good. How are you?
I'm good. I'm good. I love how we're on opposite ends of the day.
I know it's wild to me. It's 6 o'clock p.m. here, and it's what, 9 o'clock in the morning your time?
Tomorrow, yeah, for you.
That's wild. And the whole
I
like,
always say when I get on client calls, I'm like, I'm in the future. The weather looks great. I
oh my God,
don't know
that's
what else to
so
say.
funny. That's hilarious. I just feel like whenever I try to convert time zones, it's like the biggest brain blast I've ever gone through. Like trying to schedule this was hilarious.
Yeah. We're like, no, no, no. I will be asleep. No, you will be asleep. When are we both awake?
Oh man, well, we're all here. Welcome to everyone who's
Yes.
joining us. We're really excited about this conversation that we're about to have. If you're not familiar with me, if you came from Steph's page or you just somehow found this, I'm Callie. I'm an IC dietitian. IC meaning interstitial cystitis. I always forget to define that. And Steph, would you like to introduce yourself to the audience?
Yeah, absolutely. Thanks for having me. So, my name is Steph. I am based in Sydney, Australia, and I am a dietitian and nutritionist who focuses on endometriosis. And I was diagnosed with endo myself about 5 years ago.
Awesome. And how are you doing currently with symptom management?
Oh, yes, a recent topic of
Sorry,
conversation.
you don't have to get into it.
Like she went real in there. No, I'm kidding. No, it's look, I am very transparent that my symptoms of endometriosis from the jump were definitely on the milder side, but nonetheless it still impacted my life in some way. And over the probably the last 6 to 9 months, I've definitely had an increase in frequency and intensity of my symptoms. So yeah, I just recently, about a month ago, switched over my Marina IUD to see if that might just buy me a little bit more time because I'm going to travel for a couple of months. So I don't really want to be recovering from a laparoscopy, which sounds really silly and but don't want to be on a 24-hour flight with wounds. And yeah, I'll contemplate whether I go and get the laparoscopy done again later this year. But yeah, it's been a bit of a time. There's no rule books for making these types of decisions in life and the timing of them and all those kinds of things. And it's something I see a lot of people grapple with as well. So if you're in that same boat, I'm in the same boat too, despite being a healthcare professional, knowing maybe more, but those decisions still are head scratchers nonetheless.
Yeah, and I appreciate your transparency, and it's something I also try to be transparent about because I don't suffer from endo, but I have interstitial cystitis, and it's also not like a perfect journey. Like, yes, my symptoms are currently managed, but the first 2 decades of my life was just the absolute worst. So,
Mm.
yeah, I have been in that struggle bus as well, and luckily I'm not currently on it. But these chronic illnesses, you can still have flare-ups. You have to learn to, deal with it. But anyhow, let's dive into endometriosis. So thanks for sharing a bit about you and your journey. Can you define what endometriosis is and share what the common symptoms are?
Yeah, absolutely. Absolutely. So endometriosis is where tissue that is similar to the lining of the uterus called endometrium. So cells that look pretty similar to that start to grow outside of the uterus. So it could grow on other reproductive organs, bowel, bladder, and there's not many organs in the body that endometriosis hasn't possibly been found. It's just whether we're looking for it or not. To be honest, a lot of them, those kinds of studies have been quite incidental findings. But endometriosis is a whole body disease. It is typically shoehorned into the box of gynecological or reproductive health, but the symptoms and the impacts can be a very full body effect. So symptoms range from completely asymptomatic, or what's often termed as silent endometriosis, which in my opinion, usually there is still a symptom, it's just we haven't made the connection. So the most common symptom that I see in the silent endometriosis category is actually infertility. And so people won't find out that they have endometriosis until years of unsuccessful fertility treatments or years of unsuccessfully trying to conceive. And so people will say, well, I don't have any symptoms. I'm like, well, actually your infertility could be the symptom of endometriosis, and perhaps you don't have any pain or menstrual disturbances or fatigue or nausea or any of the other gut symptoms. And then you can go from asymptomatic, or people walking around with endo growing rampantly in their body and have no idea, to extremely symptomatic, incapacitated and or almost disabled by the condition. So there is this huge spectrum. And common symptoms are period pain, or heavy periods is a common one. Ovulation pain, gastrointestinal symptoms like constipation, diarrhea, bloating, or what's often called endobelly, which is this painful, distended abdomen, often looking like you're pregnant. That is very tender and painful. We also see really common symptoms of things like fatigue as well, brain fog, kind of struggling on that front as well. And there is a whole host of kind of individualized kind of symptoms as well. There's also bladder symptoms, which is particularly relevant to our conversation today. So a lot of people that I see, you know, have been told that they've got recurrent UTIs, but there's no bacteria in the urine. But turns out they had endometriosis. So you can have pain with urination, you can have issues with urination. I didn't realize personally that I had urinary symptoms until after I had my laparoscopy and removed my endometriosis via excision, because I didn't realize that what I was doing before with my urination was abnormal, and now it was more normal. And that has been a symptom that is increasingly worsening as I get further away from that surgery for me as well. So urination changes is a big one, and it's a more subtle one, and I find that a lot of people aren't really super aware of it. So for example, for me, and I'll just talk to my personal experience, but I know this is a common experience, if I need to go, I can hold it, but there's a point in which, like the point from like, oh, I can hold this, to like, oh my God, if I don't go, like it's hurting me now, I need to go. And it's not a continence issue, I can hold it, but the discomfort is becoming so unbearable. And then when I do try and go, it's like I'm constipated, like I can't start the stream of wee to go. And so that's like, when I describe that to people, they're like, oh, I have that too. I didn't know that was abnormal. And so that's a common one. Pain with opening bowels, a lot of bowel concerns. I think the statistic is about 85% of people with endometriosis will have a gut complaint over the past 12 months. So it's extremely common, and a high comorbidity rate with irritable bowel syndrome. I've probably missed like a bajillion symptoms. As random things from lower back pain to people will get random inflammatory symptoms, and it is a chronic inflammatory condition. So it is characterized by inflammation that is higher, and we have seen that in the pelvic cavity. For one, the fluid that is in the pelvis just seems to have more inflammatory markers in it. So you don't need to tick every single one of those boxes that I just mentioned of symptoms to have endometriosis. Some people will have extremely painful periods and very light periods and still have endo. Some people will have just infertility and no pain symptoms and still have endo. Some people will have fatigue and nausea and still have endo. So you don't need to have every sphere of those symptoms kind of ticked off to have a diagnosis. And I think that's something that, you know, it's great that the media talks more and more about endometriosis, but it's highlighting the extreme stories of people who are unable to work, unable to, be a parent or whatever that disability that has been caused by endometriosis is highlighted, which I think is an important and valuable conversation. However, that isn't the case for everybody. And as a result, I think in a way, for the people with the more subtle symptoms, it feels like, oh, it's not bad enough to really get help. And I think that's an important thing that I always try and, like, whether you've got no symptoms or one symptom or 25 symptoms, it doesn't matter. Like, you still need care, you still need a diagnosis, and you still need to be included in the conversation in the community.
Yeah. And while you were talking, I was like, there's so many overlaps between IC and endo. Like, it's crazy to me.
Yeah.
Symptom wise, I mean, bladder endo sounds almost identical to IC. There's just a few little things that could be different. The overlap with gut health, like, I think the statistic is a third of people with IC also have IBS. So
Yeah.
that's very similar. I was just reading an article that said both of the conditions involve pelvic floor dysfunction, and 9 in 10 patients with both IC and endo have pelvic floor dysfunction. So that's a big overlap as well. I didn't quite mention that, but we were probably going to get into it at some point.
Absolutely. I know the Venn diagrams are Venn diagramming, like, really, like, between, like, IC, endo, IBS. There's a few other, like, adenomyosis, which I always call the kind of ugly stepsister of endometriosis. Like, a lot of these symptoms can kind of, like, overlap to the point where it becomes very hard to tease out and diagnose each of those things, because, you know, it is extraordinarily easy to be misdiagnosed, and to be diagnosed with endometriosis, it can be quite invasive and time consuming and expensive and painful. And so people don't want to go down that path, which is, you know, lightly, which is fair enough, but that is also contributing to being misdiagnosed as well, because these symptoms can be quite broad or vague, or could be, you know, something else, or you could have multiple of these conditions simultaneously as well. So I think all those things make it really tricky to find out that you do have endometriosis in the first place as well.
For sure. So in talking about diagnosing endometriosis, I mean, I'll just take you through the IC diagnosis process, and then you can share, like, similarities and differences. So essentially, IC, it's a diagnosis of exclusion. So the doctor will want to run any relevant testing. They might want to do, I'm blanking on the term for it. Pelvic ultrasound. They may want to do a cystoscopy, so a scope of the bladder, and maybe a couple other tests. But if they don't find anything that can explain your symptoms, then they will give a diagnosis of interstitial cystitis. Now, it gets kind of unclear, because if somebody were to be suffering from endometriosis, maybe bladder endo, like, and they didn't have a laparoscopy. I mean, why don't I let you explain what that is first, and then we can get into that.
Yeah, no, that's, yeah, perfect segue to the potential crossover. Absolutely. So endometriosis, which affects about 1 in 7, is the latest Australian statistic. So by the time a person that's born with ovaries, or a woman, reaches about her 40s, 1 in 7 of them would have had endo in their life. So it's common. And in my opinion, I think what's happening is that it's over time has become a diagnosis of exclusion where it should never have been. It should always be, like, one of the first things that we're talking about, because it is so common. So we have to think about it, you know, up front. In terms of the diagnostic process, people don't go in and say, I have period pain, let's do a laparoscopy tomorrow. That's not in reality the process that happens, although that would be nice. A laparoscopy is a keyhole surgery. It is the process that is commonly used in many procedures, not just endometriosis. So if you get your appendix out, they do that laparoscopically. Ugh, that word. which basically just means that they, instead of cutting you all the way open, they're just doing holes and they're putting cameras and lights in to visualize the field. And then the actual surgical removal of endometriosis, which is called excision surgery, where they cut out the endometriotic tissue and then they have to send that to a laboratory for pathology to confirm that that tissue is in fact endometriosis, because other things can grow in your pelvis too, like big C word, you know, so we need to make sure that that's not that and that it is in fact endometriosis from the jump. So that is the quote unquote gold standard. Now, the gold standard of diagnostics is going to change because we want less invasive than that, because you've got to go under anesthesia, you're going to have to recover from that procedure. You know, there's always risks whenever we do a surgery, right? So that's the ideal situation, because you're getting the tissue out, you're sending it to pathology, and it's come back, it's saying it's endometriosis. That's the best. But more and more developments are happening now in imaging particularly. So we're starting to get better at being able to train specific sonographers to do an endometriosis related ultrasound scan and start to see some of the disease. Now, it is extremely dependent on the skill of the sonographer. You can't just rock up to your regular radiology place and go, oh, do a pelvic ultrasound, they found endo. Unless the endo is extremely progressed or very severe and it's completely distorted your anatomy, which does happen, but usually it's not going to get picked up at that point, unless your sonographer is extremely well trained and knows what to be looking for. So for example, usually if you've got less progressed disease and the disease is staged in 4 key stages, stage 1, 2, 3, and 4, which is, I mean, there's a bunch of criteria that go into it and where it is and how much and the size of the lesions and things like that, which I won't go into. But basically, the less progressed the disease, the less likely you are to really find it on an ultrasound. And the more progressed the disease, the increased likelihood you will find it on an ultrasound. So, and that's a very broad generalization. There's also a form of endometriosis called an endometrioma, or it's often referred to on sonography reports as a chocolate cyst. And that is actually a cystic form of endometriosis that is on the ovary. That's very easily visualizable on an ultrasound scan. Obviously, they can visualize it, but they can't tell you what it is from an ultrasound. So you still may need the surgery anyway. So these scans are now being used for both diagnostic purposes and also surgical planning purposes. But like I said, it is extraordinarily dependent on the skill of the sonographer. And there is so much greatness that has in terms of accessibility, invasiveness, time, money, energy, and I'm all for it. But on the flip side, for somebody like myself and the many people who have less progressed disease, like stage 1, stage 2, you can go in for as many ultrasounds as you want and they say you're normal. And so it doesn't necessarily mean the disease isn't there or hasn't come back. And so that's the tricky part, because it could be delaying people from getting more intervention if the ultrasounds are coming back clear. So it's like, if it's a yes, it's probably a yes surgically. If it's a no, it doesn't mean it's a no in surgery. And I think that's the tricky part with scans. Other tests, there are no blood tests that are accurately able to diagnose endo. You'll see lots of people getting sent off a marker called CA125. That's a very general, broad marker that could pick up anything from endo to cancer to PCOS to anything. And then heaps of people with endo have normal CA125s. So it's a non-specific and non-sensitive marker to endometriosis. So it's kind of a bit of a, like, it's not that helpful. And so really there's no lab test that's going to confirm the endo. The scan will increase your suspicion for some people, but not for others. The surgery with a skilled surgeon is the kind of ideal. And so that is how it is diagnosed. You can also make a clinical diagnosis, which means you're so suspicious that this person has so many symptoms that we're just going to pretend like you do have endometriosis, because you probably do. And so, yeah, there's a fair amount of that as well, whether that be delaying surgery for reproductive reasons or other reasons, financial, budget, time, et cetera, et cetera. So, yes, all those things can lead to a diagnosis of endometriosis.
And it takes, like, a lot of the time, years for people to be diagnosed, right?
Absolutely. So 6 to 12 years on average.
That
So
is
yes.
insane. Like, blows my mind.
Yeah. It's wild when you come into contact with somebody who may be in their 40s or 50s and they tell you about their first period as a 12-year-old and the symptoms were there from there. And it's like so many decades of this person's life has been impacted by this disease and nobody has talked about it. And there is a generational thing as well. Like often I take a family history when I see my clients. I'll ask them about their parents and their sisters and their grandparents, and the rate of people's mums having hysterectomies because they had heavy periods, but no diagnosis of endo or adeno or fibroids or anything. That's what they did. That's what they did, 20, 30 years ago. They would just say, oh, you don't like your periods? Cool, do a hysterectomy. Don't worry about it. And so that doesn't solve the endometriosis, mind you, but for them, it helped the period part, obviously. There's also all these consequences of hysterectomy. But it's fascinating because it's just like, oh, like there's probably a familial link here with endometriosis because we know that if you have a first-degree relative with endometriosis, your risk is a lot higher. But we will never have confirmation of that because they just weren't looking for it. And so there is this kind of generational awareness that it's improving, which is great, but we don't have the history to track it back and be like, actually, my mom probably had endo and my grandma probably had endo, but nobody actually said anything or investigated it, and we won't know now.
Right.
Yeah.
Yeah, that's hard. I had the same thing happen when I talk to people with IC where they're like, yeah, I've struggled with this my whole life, but I didn't get diagnosed until I was like 40. And I'm like, okay, that is just ridiculous. But in terms of getting diagnosed, like what type of practitioner will somebody get that diagnosis from?
Yes, ideally it should be somebody who is a gynecologist who's had additional training in surgery for endometriosis. It's arguable whether, it falls into gynecological umbrella because of the period related symptoms. But like I just said, it's a whole body disease and we're trying to break this tie that, endometriosis is not the endometrium. So how is it then always constantly being tied to being a reproductive disease? Is it just because it can impact fertility for 30 to 50% of people? And so in an ideal world, we'd have like a whole separate specialty where we'd have endo trained people. But right now, gynecologist with adequate training and surgical skill in endometriosis, which sounds like I'm really emphasizing that, but there is a lot of people that do not have that. And just because they're a gynecologist doesn't mean that they will. You want to ideally be seeing someone who just sees endometriosis or pretty much just sees period pain, pelvic pain all day, every day. Not someone who's, doing a bunch of stuff and doing, IVF for pregnancies and blah, 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 blah. You kind of want someone who's really honed in on that.
Yeah. Same goes for IC. I mean, most urologists really are treating men, they're treating prostatitis, they're doing surgeries. They're not really specialists in interstitial cystitis. So you really do want to do your research when looking at a practitioner. Sometimes even a urogynecologist might be better, but who's to say? I mean, it all just comes down to the practitioner. So yeah, it's really tough. And one of the symptoms you mentioned that definitely could be a crossover with IC is the endo belly, because we have something that we call IC belly, which a small subset of people do experience like that abdominal bloating. And I've always thought, could it be possible that these people have endo? Maybe they have some sort of GI issue. Like, I just think it's an interesting thing or symptom crossover between all these conditions.
Yeah, absolutely. No one's really like studied the symptom properly, like in the literature. My like working hypothesis is it's a combination of two main things, which is inflammation in that region. And so your body is putting more, white blood cells and fluid and blood flow to that area in hopes of trying to deal with whatever is going on. And then from an endo perspective, and I'm not sure if you could corroborate this with IC perspective, but you've also potentially got some gastric expansion, maybe some bloating, maybe some fluid retention, maybe some food intolerances, maybe, you know, a few different things. And those two things combined, it's like boom, like this bowling ball in the belly situation. That is obviously uncomfortable in physically, but I also find it's a big psychological stressor for a lot of my clients as well, because you've got people coming up to you on the bus saying, oh, do you need a seat? How many weeks are you? Or you've got the body image of like, oh my God, my body has just changed so much. Like, I'm not processing this. There is a lot of impact of that symptom on your daily life. Like, oh, I can't fit my pants anymore. I'm at work. What do? I can't undo my jeans. I'm so uncomfortable. And it's exhausting. And we know that the gut and the brain are connected. So if you're in that much pain in your abdomen and your nerve endings are in so much pain, of course it's going to put you in a bad mental state, at least temporarily as well, because you're not feeling good. You know, when you're sick, you're down and feel sad and sorry for yourself and all that kind of stuff. It's, you know, we can all relate to that kind of feeling of having a cold and feeling that way. And so this is a chronic condition where it's chronically doing that to you and you're chronically feeling bad, both mentally and physically. It's a really tricky situation, but focusing on it from an inflammation and gut health perspective, as well as also the nerve endings, I think that's like the trifecta. From an endobelly perspective, can be quite helpful to try to reduce the frequency and intensity of it. It can still happen. Like I said, like I have this post that went like got really popular, which it was a picture of me with endobelly, and it was like, sometimes it's because of what you ate, sometimes it's not. Sometimes it's because you were stressed, sometimes it's not. Sometimes it's just going to happen just because, and it's nothing that you did or didn't do. And you can't have 100% win rate with a chronic condition. We're just trying to get 50%, 80%. We're just trying to get it better. And so I think that's a really important mindset to have, particularly when talking about, you know, how does diet and lifestyle play a role and all that good stuff. So yeah, I think it's a really tricky symptom, but it's something that when you have that multi-pronged approach, it can definitely improve.
Mm-hmm. And there's a question that says, have you seen an increase in SIBO diagnosis with endo and IC? I've had a couple clients with a history of it, but nothing that really sticks out to me of like, oh, this, like, there's something here. Have you noticed anything there?
There's definitely, I would say, of all the people that I see that have SIBO, most of them have endometriosis. I don't personally manage the SIBO, I refer on, but it's definitely there. I don't think it's as prevalent as, say, something like IBS or general constipation diarrhea symptom set. But the other tricky part is the symptoms of SIBO. Again, they cross over a lot with common symptoms of endo, for example. So fatigue and low iron and all those kinds of things you're going to see that in endo anyway. So it's tricky to think, what do you do? Yeah.
Right. So talk to me about treatment. What are the treatment options for somebody with endo?
Yeah, I always like rephrase it, and I'm like, what are the management options? Because there is no cure for endometriosis.
That's a great
nothing treats it. And that is the facts. Sadly, 190 million people worldwide are living with endometriosis, and there's no cure, and we still don't know what causes it in the first place, which is just bananas bonkers. That's like somebody not knowing what causes diabetes or asthma, because that is how prevalent it is in our society. So imagine we don't know what causes asthma or how to fix it. It's like pretty crazy to think about. I have asthma and I get so much care for that, and in comparison to the care that I get for endometriosis, it really blows my mind. But anyway, management options are, the first, like top of the pyramid, is surgery. So excision surgery, where they cut out the endometriosis rather than ablation, which is they're burning it or, you know, cauterizing it. So you want to actually try wherever possible to have a surgeon that is going to cut things out rather than just burn it away. That's kind of the tippy top of the pyramid. Other options are like hormonal suppression. So endometriosis is an estrogen-linked disease. So it does seem to both respond to and potentially produce its own estrogen. That isn't universally true, though. There are situations where that doesn't occur, but it is a commonality. And also because of how period-related many of the symptoms are, suppressing the period or managing the period seems to be a key focus for management, medically speaking. So a lot of people get offered IUD, pills, medical menopause drugs, basically drugs that will switch off your period completely, bring your hormones down to zero. Now, obviously, there's heaps of side effects and, pros and cons of all of those. So I'm not going to get into the weeds of that. And got to make your own decisions based on your life stage, your values, and blah, 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 blah. But they can help some people. They can be nightmares for other people. It is so individual, just like any medication is, right? So that's kind of like your main medical options, if I'm honest. There aren't many. Surgery or suppress your period, really. And I think this is a common frustration in the endo community is like, well, what else am I to do? And I'm just like, well, they're not going to give you options that don't exist because that's all we really got. So like, sadly, that's the state of affairs. So then you come down to like conservative or lifestyle management. So the big ones here are pelvic physiotherapy, like you mentioned earlier, Callie. Pelvic floor dysfunction, pelvic dysfunction in general is a common feature of endometriosis, because if we're constantly in pain, we're constantly tightening, like whether you know it or not, you're constantly clenching and tightening and and that in and of itself can refer and cause pain up the body. So working with a pelvic floor physiotherapist can help with managing that, exercises, stretches, relaxation strategies, all that kind of stuff. It's very different to just going to your regular physio because your knee hurts, okay?
Yeah.
There may be fingers first in places. If
I have a whole episode of my podcast dedicated to what to expect. So if anybody needs that, fabulous. Go listen.
Please listen to that. The first time I told a client who'd never heard of it, she's like, what do you mean? And I was like, oh, it's a bit different to, going because your back's sore. And she's like, oh. She's like, are they qualified to go there? And I'm like, yes, they should.
Yeah, it's weird until you get used to
it.
You
don't have to, by the way. If you don't feel comfortable with that, you don't have to do that. But no, you don't. That is part of the kind of typical appointment with pelvic physiotherapist. Diet then becomes another one. So focusing on foods that help reduce inflammation, working through any gut-related concerns, troubleshooting those, the cyclical dysfunction, if there's any kind of, this estrogen situation, not enough progesterone. This is very common features of endometriosis in terms of the cycle, and then that typically also all that concoction translates to fertility for a lot of people, whether they're thinking about future fertility, currently trying to conceive, have been doing IVF for years, wanting to freeze their eggs. And there's a subset of people that don't care about having kids ever, which is fine too. But that often comes into the conversation as well. Acupuncture can be also valuable, and sometimes traditional Chinese medicines also used alongside that, which can be helpful. And honestly, they're your main management strategies. The other one that's been really new kid on the block, which has had good effect, is the use of cannabis-related products, so like CBD oil, medical cannabis, and obviously like psychology support, pain management. You can go into a different kind of like branch of pain management. So you can see a pain specialist and get, proper pain medications, not just, ibuprofen and paracetamol. We're talking like the bigger boy drugs. If you're in chronic pain, and there's whole pain teams that sit, like especially in Australia, we have like whole pain teams for that. It's kind of like a separate offshoot to endometriosis, I feel, because the way that they're thinking about it is they're not thinking about the disease itself. They're just thinking about the pain, because all they're trying to do is manage the pain. Whereas that other pyramid I was talking about is trying to deal with the symptoms of the disease. Mm-hmm. And I think just one note on pain before I finish my little spiel. I went to a conference last year, the World Congress on Endometriosis in Scotland. And there was an incredible speaker, and I don't remember their name, on pain and chronic pain. But the one thing that really like opened my eyes up to like talking about pain was the statement that not all pain is dysfunctional tissue being present, like in the case of endometriosis, right? Like not all pain is going to be a sign of the disease. You can have pain and there be fresh off an excision surgery and technically there's no endometriosis there, you can still be in pain. It doesn't make your pain any less valid, just means now we're dealing with a pain disorder. That's almost like, it's like the endometriosis trained your body for pain. The endo is now gone, but the pain syndrome is almost still there. And I think that's not like well articulated very well. And I think it's also just not like socially acceptable to talk about, because it's like, oh, you're telling people they're in pain, but there's nothing there. And I'm like, no, not like in a gaslighty way, like in a like, we need to also move away from just focusing on the endo part and actually focus on the pain part, because that's what's actually hurting your life. So yeah, anyway, I could talk about that all day, but I think it's one of those things that endo can morph into almost these other types of offshoots of chronic pain disorders, and see lots of things like fibromyalgia, and like we talked about IBS and all these kinds of things. And it can all feed into this like tornado of chronic pain. And I think that's an important thing to keep in mind. You know, we're rarely, I don't know about you, but I'm rarely seeing people just come to me, oh yeah, just got endo, that's it.
Right. Yeah.
It's like, I've got endo, I've got celiac disease, my thyroid doesn't work properly. Oh, I have migraines. Oh, I have this. Mm-hmm. It's never just one thing.
Yeah. I see that too. And I think for a lot of people with interstitial cystitis, there's a huge nervous system component, and that plays into the pain. I mean, it's crazy. We could have a whole other like 3-hour conversation about that.
Seriously, like pain stuff. Like when I was at that conference, I was like, oh God, my mind has been blown.
Yeah, no, it's crazy. Question, if somebody gets the excision procedure, can they be symptom free after that? Like, does it come back? Like, what happens?
Yeah, great question. So I read a statistic the other day that 28% of people that have a therapeutic laparoscopy, so one that's designed to try to reduce symptoms, versus like, for example, fertility preservation, where you may leave some endo in because you want to leave an ovary behind or something like that. 28% of them will have symptoms after the surgery. So it does happen that you won't get relief. I think that's a subset of the endo community that's not very well managed or heard. But most people will get a bit of a symptom reprieve from excision surgery. The duration of that symptom reprieve is extraordinarily variable, and it's often not as long as what perhaps the doctors start to tell you. So, you know, I've seen people get, you know, relief for 6 months to a year, to, you know, have one surgery, don't need another one for 10 plus years. You know, there's a huge scope. And I think that probably is related to that nervous system piece that we also talked just about. But there's a 40 to 80% basically regrowth rate. Because if you think about it, it's like pulling out a weed in your garden, right? You pull out the weed from the root, but you don't know how the weed ever got there. So you go out to the garden again in 4 weeks' time and there's new weeds. How did they get there? Well, I don't know. So I have to pull it out again. So if you don't know what's causing the disease in the first place, you're just cutting it out, it's going to grow back at some point in most cases, because we don't even know how it got there. So until we target, like, how did it get here, I don't think we're ever going to get to a point where we just do one. Like, in the ideal world, we have one surgery, we're done. Get it all out, job done. But it's a very, like, it's almost like a cancer approach. Like, oh, we'll get the tumor out and do a little bit of meds and chemo and whatever, and then we'll check on you, make sure it's all gone, and we'll keep checking on you, make sure it's gone. And I think almost in a way, because we don't know what endo really is caused by, we've had this kind of similar approach of like, oh, we'll just cut it out and then we'll wait a bit and we'll see if you feel bad again, and then we'll go in and cut it out again. Because it's not going to kill us, because the tissue itself is benign, not like unlike cancer. It's not going to kill us per se, and it's questionable, may hurt our lives so negatively, but I think that's always been the approach. And I think in, 100 years time, probably whilst I'm dead and gone at that point, but like, I think we're going to look back and be like, that was so archaic. What the heck were we doing cutting that out? Like, that's bonkers. Like, duh, you just find the cause, you find a medication, you find a strategy that targets the cause. It doesn't grow anymore. Simple.
Right.
Which is what a lot of like new therapies for other, diseases are coming out with, So I think that's the clincher. We're still so focused on the surgery part, but I'm like, we still don't even have the starting point yet.
And that reminds me, it's very similar to the approach with IC. So in about 10-ish% of people diagnosed with IC, they have Hunner's lesions, which are open wounds on the bladder wall that you can see on a cystoscopy. And the treatment for them is fulguration, so essentially like burning them, kind of similar to what you were mentioning earlier. They don't cut them out, but it's like these people can have extremely variable results. They can get significant symptom relief for months, maybe years, but then there's some people that just have symptoms like right when they come out of surgery. So it's just so up in the air. I think we're just so desperate to get people relief. Like, we're just trying everything that we can. So it's just interesting how it's so similar.
Yeah. I think a lot of chronic conditions that disproportionately affect females have similar features. And I think particularly women who are younger. And you know how we're talking about like that delay to diagnosis? Like, there's a part of me that just thinks like how paternalistic, medicine has been. I don't know, we're moving away from that, but how it has been. Like, imagine being 18 or 19, going to your doctor and being like, something's wrong, da 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 da. Easy to be placated in that paternalistic model and contribute to that delay. And so I think a lot of the options, the underfunding, the lack of options, the lack of research is because there's an inherent sexism in how, all this is handled and managed, because you'll see people comment on social media, this affected men, we'd have a solution by now. And I'm just like, we're never going to know that. But like,
well, with IC,
it's an interesting thought,
With IC, men actually have it. They're definitely less men than women, but like, we still don't have a cure. So, I mean, you could say if more men had it, then maybe we'd have a cure. It's just, you don't
I
even
don't know.
But I understand.
I know. It's one of those things.
Yeah.
We're probably of, few decades behind where other parts of, medicine and research and funding is at. And it is frustrating because, it's probably not going to help us in our lives. It's probably more for the future of our children and things like that. But it is frustrating and it is tiresome, as I'm sure you can relate to. But yeah, absolutely. Just thinking about burning the open wound in the bladder is just such a strong visual, and I'm just like, oh.
I know. It's brutal, I've heard, but I mean, it can get them relief. There, you could also get like steroid injections. There's some experimental stuff that you could try. It's just like insurance doesn't always cover it, so it can just be very expensive.
Yeah. So does the conservative management strategies for endo kind of correlate similar to IC?
Yeah.
Like pelvic physio, diet, all that kind of stuff?
Yep, all of that. Pelvic floor PT is like one of the most researched, recommendations for treatment for
Mm.
IC. That has helped me the most personally. Diet. So we have an IC diet. It's made from it's really based off of anecdotal evidence. So basically people saying this is what I think bothers my bladder. And so they made a diet out of it and it kind of transformed into this big monster. Everybody's afraid to eat, there's all these bad foods.
Oh
What I'm
no,
finding is
diet's such a nightmare.
people really aren't that diet sensitive. If you have Hunter's lesions, yes, you have a higher likelihood of being diet sensitive, but most of us don't have those. And so the recommendation is an elimination diet. So that is probably the one difference. I didn't hear you mention an elimination diet. So yeah, that's the recommendation. There's some meds. We have one FDA approved med, but there's some lawsuits going on with eye damage. So that's kind of like nobody wants to do that anymore.
Like,
It's crazy. Antihistamines, antidepressants. There's lots of things you could try, but all of it's just trial and error.
yeah, yeah. I think somebody was talking about trigger point injections in the chat, and that just triggered my memory. There's also some people that get pelvic floor Botox as well,
I had that.
to help the pelvic floor as well. So that's a common option that can be offered in endo as well. Yeah.
Yeah. I will say it was painful, but I think it helped a bit. But the second time I got it, my
Mm.
insurance didn't cover it and it was expensive. So
Yeah.
one of those things. And I saw we had a couple other questions. And I wanted to ask you this one. So is there a link between adenomyosis and IC that you know about? I haven't heard anything of that nature.
So let's just quickly talk about what adenomyosis is before we launch into that. So adenomyosis is a condition that is often referred to as like the ugly stepsister of endo, like I said. And basically it is where there is a mass or an inflammation of the endometrium invades the myometrium, which is the muscle layer of the uterus. And you can get these kind of forms of adenomyomas. It can be quite diffuse, it can be quite cystic, but it can generate very similar symptoms to endometriosis. So heavy periods, painful periods are much more dominant feature of the symptom set of adenomyosis. Look, adenomyosis is even more under-researched, underfunded than endo. So every time somebody's like, what's the best diet for adeno? I'm like, they haven't even looked at that yet. Or like, what's the relationship between adeno and this condition? I'm like, yeah, there's no studies on that yet. Like, it would just be anecdotal. So yeah, I guess because the features of adeno and endo are decently similar, you could say there could be some relationship. But whether it's one's increasing the risk of the other or whether there's just a high co-occurrence is a different story. So no, I don't think you'll find anyone who will give you a really solid answer on that. It's just more about your personal experiences, I would assume.
Okay, good to know.
Yeah.
I think we had two people asking, is the laparoscopy worth it? Or were they asking about excision?
Yeah, I mean, it's gonna be so individual. Like it's going to depend on I have this question posed to me in clinic all the time from clients. I'm just like, I can't make that call for you. Like, you got to do it. Like, I'm not the one going under the knife and taking time off work and paying for it. And I mean, I have, but like, I'm not doing that right now. And it's a way up of like, how bad are your symptoms? What are the consequences of doing nothing? You got to do your pros and cons, your costs and benefits, and work out if it's right for you. But can you manage endo without surgery for some time? Yes. Should we always be doing that? Not necessarily. And I think the unspoken part about endometriosis is that you can lose organs to this disease if it progresses. I have clients who've lost ovaries, fallopian tubes, parts of their bowel, have to be catheterized long term, have had stomas, somebody's lost kidneys before. Like, this disease, if it gets really bad and really progressed, you can lose an organ. So if you wait, there's always that kind of risk. So I think the risk of doing nothing is actually decent. and the risk of doing something is also decent. So I can't possibly weigh all that up for you. What if you ask me personally, was surgery worth it for me personally as somebody with endo? I would say yes. I think it got me good relief for a good amount of time. You know, I live in Australia, so we don't have to pay ridiculous amounts of money compared to the States, but it's still expensive. To get the surgery done, I would definitely do it again. But I don't necessarily want to do a million surgeries in my lifetime for a variety of reasons. But the scar tissue that's left behind can be problematic in and of itself, not just the disease itself. So I think those are all factors for consideration. The ideal situation is if you're contemplating surgery, you find a really good surgeon that you trust, that you know knows endo inside out and upside down, and you do a thorough surgery and try and stretch out the time between and subsequent surgery if required for as long as practical with conservative management.
Mm-hmm. Yeah.
Well, at least that's my approach anyway, but everyone's going to be different.
Yeah. We can say that for so many parts of IC and endo. So I like that answer.
Yeah.
And then I saw a question about diet for endo. So you answered that earlier. So generally like an anti-inflammatory type diet pattern.
Yeah, I mean, there's like, you can make it as simple or as complex as you kind of like. I mean, the most simple version is an anti-inflammatory style diet. There is no single best dietary pattern for endometriosis. It's kind of a hodgepodge of what we know from some of the science around what food groups are, you know, more likely to increase inflammation or increase symptoms and what are more likely to reduce. So diets that are very high in red meat, processed meats like bacon and deli meats, saturated fats, trans fats, alcohol, seem to be not great for inflammation and endo. I mean, surprise, surprise, there's no surprises there. I mean, it feels kind of obvious. And then the foods that seem to be helpful are your fruits, your vegetables, seafood, healthy fats, extra virgin olive oil, avocado, nuts, seeds. Dairy foods seem to be beneficial, which is a common point of contention, but the large-scale studies seem to show that dairy is beneficial. Obviously, if it makes you poop your pants, don't have it. But like, if it doesn't make you poop your pants, have it. Like, I don't know. Like sometimes I feel so obvious saying that, but you know, people just take it at face value. Yeah. This is the point. If you don't work with someone one-on-one, you're not going to get that personalization application. You're going to have to take the general information and make it work for you. Hey, it's been getting on my nerves lately. Can you tell?
That's so funny, but good plug. You know, work with us, work with one of us, and we'll help you. We'll individualize it for you.
Oh my goodness.
That's so funny.
But maybe people don't have it. It's real simple.
Oh my goodness. Is there anything,
I've already answered that.
Is there anything else you wanted to say before we wrap this up?
Look, I think the common thing that I'm starting to see now, whilst it's awesome that diet is getting more attention in the endometriosis space, where it probably didn't when I first started out about 4 or 5 years ago, I also think what comes with that is a higher risk of people taking it too far. And it becoming disordered to their detriment. And I think that is a warning that I think needs to be on a lot more of the conversations that we have, because yes, we should be eating mostly fruits and vegetables and whole grains and healthy fats and da-da-da-da-da-da. And yes, that is true. But if you put, you know, a morsel of beef in your mouth, it doesn't mean you're going to burst into flames either. So I think that's really where a dietitian is so well placed in a one-on-one context to like help you work out like, oh, you're being too perfectionistic with this. We need to actually integrate this more flexibly and have a lot more, you know, wiggle room with how you're applying all these principles. And then simultaneously, the people that apply it, you know, 20% of the time and 80% of the time they're not. And then they're like, wow, I'm not getting results. So, you know, you'll kind of get either end of that spectrum. And I think that's a particularly important, you know, conversation to have, because there are some small studies emerging showing the high rates of eating disorders in people with endometriosis and IBS and people that have endo and IBS. So
if there was research on IC and eating disorders, it would be there. Like, I'm confident in that.
Oh, I believe it.
Yeah.
And I think particularly whenever there is, discourse about diet or elimination style diets, like commonly used diets in endo are like the low FODMAP diet, and you'll see people saying, should I be going vegan, and and like all of those things can potentially work, but the question is like, I'm not willing to go vegan. Sorry. Like, I'm not willing to go vegan. Like, I'm Greek. I'm going to eat lamb on the weekend. Like, it's not going to happen. So, like, I wouldn't make that sacrifice. Like, anyway, like, even if it did help my pain, I probably still wouldn't sacrifice it forever. So, like, because I value that other part of my life, like cultural part of my life and socializing part of my life. So, like, it's going to vary, but I think when your diet becomes the thing that you're clinging onto like a life raft to deal with all of your problems from an endo perspective, you need to diversify and you need to de-emphasize it a little bit, because it is important, but it's not that deep, you know?
Yeah. No, I mean, I could have said literally everything you just said, and it applies to IC as well. So thank you for saying it.
My pleasure. I'm just, obviously, we're all just suffering similarly all over the world.
Oh my gosh. Well, you keep it real, and I love that about you.
Always, always. You've got to keep it real. Otherwise, what's the point? We're just, yeah. I mean, I think it's one of those really tricky things. You want people to be invested and you want people to pay attention to it, but you don't want it to, take over their lives and become a negative. And if it's stressing you out, it's probably there.
Yeah, absolutely. Well, I feel like this is a great place to wrap this up. I just want to say thank you for giving us the last hour of your time to talk about this. Happy Endometriosis Month. If anybody has any questions or wants to learn more about you, go follow Stef. Are you currently accepting new clients?
Yes, I just opened up a few more spots, so come on over. I'm sure they'll disappear shortly. So if you're watching this in 3 months' time, probs not. But yes, our handle is at endo.dietitian. I also have a fertility page, which is at @the_dietologist, and TikTok, and our website is thedietologist.com.au.
Perfect. Well, thanks again for joining us. And yeah, thank you everyone for tuning in. This has been a really great chat. And yeah, everyone have a good night.
Thanks, Callie.
All
Bye,
right.
everyone.
Bye, everyone.